four main emergencies to look out for when it comes to eyes. And that's going to be any acute angle closure glaucoma, severe uveitis, acute loss of vision, or a significant corneal ulceration. Those are going to be functional issues that occur with the patient. We also have to worry about possible traumatic trauma that could occur. We want to know ahead of time when they come in, was there trauma or was there not trauma? Do they have vision loss? In my mind, visual acuity is the vital sign of the eye. If someone normally sits around 125 over 126 over 82 blood pressure, now they're coming in with 220 over 120, that's a big deal, right? Same thing, if someone normally sees okay out of an eye and all of a sudden, boom, they lost their visual acuity, that's an emergency, okay? Is it painful or not painful? And the fourth question you have to ask yourself is, where's the red? When I ask about a red eye is usually benign until it's not. And then it's a big, and we'll approach that. The first thing we want to take a look at, though, is how do we look at a painful eye? So I linked to a podcast from emergency medicine cases, and that should be on the website as well. It's in the notes. 3 types of eye pain. One is a sort of a scratchy sand in the eye pain. It feels like there's something, a foreign body in the eye, some sand in the eye. That's usually going to be a conjunctival type of infection. That's going to be maybe conjunctivitis. It's something which is fairly limited to the conjunctiva, and that's fine. I can live with that. It might be the lids as well. Might even be an actual foreign body. Sometimes you have a deep, like boring behind the eye, almost a toothache pressure. That could be one of the posterior structures. It could be glaucoma. It could be sinuses. And then you have photophobia. If there's photophobia involved in a painful eye, which means even when I shine it in the non-red eye, the right, like the left eye, the red eye hurts. That means something is happening with the constriction body of that eye, the uveal tract, possibly the ciliary body, and that would also be more concerning because it's much more posterior to the conjunctiva. Give you a little more of an emergency.
Yes, you.
Those 3 different types of pain make sense. So just keeping that in mind will help us approach these. So let's go with these. This is a fantastic, what would you say this is? Looks scary, but what is it?
Subconjunctival hemorrhage.
Subconjunctival hemorrhage, very good. Either you picked up by looking at the picture or you read the title. So this is not such a big deal. This goes away on its own. It looks scary, but it goes away on its own. What makes me feel good about it is if I take a look at the ciliary body, specifically the limbus, there's no injection of the limbus itself. This happened to be an eye post-surgery, posterior bismuth surgery, right? So you can tell that there's the limbus itself, that white area around the eye is spared, which tells me it's not something affecting the deeper structures. There's no changes in visual acuity, it's not painful, there's no photophobia, no discharge. Super, love it. Now this eye looks scary because it's all yellow, but why is it all yellow? Put fluorescein in it, right? Also looks scary because it looks like it's actually being retracted by in the middle of surgery. So yes, that does. But what do you see there in the eye? That's a classic dendritic lesion, right? So herpes, HSV, photophobia could be involved. Again, there'll be the eye redness, decreased vision. May even be corneal scarring. In such a case, if that would happen, topical antivirals, no patches. Do not create, in general, we almost never put a patch over an eye. Because what you're doing is you're creating an anaerobic environment. You're creating a vacuum in that area and all sorts of nasty bacteria can grow. Another type of emergency would be ultraviolet keratoconjunctivitis. So that's either after skiing in sunny weather or water sports, or being on a tanning bed or welding without proper equipment. So it happens about 6 to 12 hours after exposure without there being proper eye protection. There might be some conjunctival injection, tearing. There'll be sort of a diffuse superficial uptake with fluorescein, maybe. Not much you can do. top anesthetic, cold compress, stress, analgesic, lubricating drops, and cycloplegics. Cycloplegics are drops that you put in the eye so it doesn't constrict. Okay, because it's going to be painful for it to constrict. And tell them you need to wear sunglasses or proper eye protection next time. That's it. That's all you can do. In general, when it comes to the two things, we always consult with opto first. One is topical anesthetics. Why? Because people need to feel their eyes. One of the major reasons we don't put things in our eye as often as we do is because it hurts, right? So we want people not to accidentally scratch their eye or damage it if we can feel it. So have an opto be on board with that. And steroids, we almost never give in, at least in the office, unless you have opto on board. That's ophthalmology. Here's a classic corneal abrasion. Probably what happened was this person, looking at that pattern, may have had something underneath their eyelid and they're rubbing at it a lot and it ended up just scratching the cornea. They come in, it feels like there's something in their eye. They might have excessive hearing, blurred vision, photophobia. But after doing good fluorescein, you can see, fluorescein these things, you can tell that it's just corneal abrasion. So you treat it with antibiotic drops, topical NSAIDs, as well as cycloplegics. If contact lenses are involved, so listen, the one thing you must always ask with any conjunctivitis, even just a basic infectious and conjunctivitis, is do you wear contact lenses? That will protect you from any malpractice. Okay, because if they say they wear contact lenses and you don't give them appropriate anti-pseudomonal antibiotics, it will cause complications. Okay. If you notice this in the whole corneal tissue, get opto on board. In general, make friends with a good ophthalmologist so you have no problem sending pictures to. It's just incredibly handy. And make sure there's no iritis. If there is iritis, we need to do mydriatics, steroids, and ophthalmology. Just has caused inflammation of the irises. Corneal ulcer, though, is a infection which involves multiple layers of the cornea. Usually after breaks an epithelial barrier, you have to treat it aggressively with topical antibiotics. Again, checking for Pseudomonas if they normally wear contact lenses. And don't put a patch on it, because that's also going to cause Pseudomonas to grow. And if there is iritis along with a corneal ulcer, make sure to give them cycloplegics to help with the pain. And we need to see ophthalmologist in the next 12 to 24 hours. Taking a look at the 3 different types of fluorescein exams you might see an abrasion, it's more superficial. The ulcer here is going deeply into the stroma, possibly infectious, could lead to permanent vision loss, especially because people wear contact lenses all the time. And then basic infectious keratitis here. Infectious keratitis for the contact lenses more often. In fact, keratitis can be, especially if infectious, one of the second leading causes of corneal transplant worldwide. If you notice a keratitis stain, make sure to have them follow up. Any questions on abrasions, ulcers, keratitis? So we talked about the idea of iritis. Iritis is when it's a little more posterior, when it's affecting the cilial body. It's also called anterior uveitis. This can be an emergency. It has to be seen with an ophthalmologist. It could be hours or days of unilateral eye pain. Even when you give anesthetic, it doesn't get better. Often those fluorescein drops that you guys practice with, only get practice with strips, but often there is a topical anesthetic that you would put on. I put in the drop, or sometimes fluorescein drops themselves come with a anesthetic, and you might see like an almost immediate relief pain. If it was not iritis would continue to hurt even afterwards because it's so much deeper. It's an inflammation of the iris itself. There might be some blurred vision, always a red flag. Might be consensual photophobia, meaning light in the normal eye makes the symptomatic eye hurt. There might be tearing, but no discharge going on. And again, that limbal flush, the ciliary flush, you can sort of see it in this patient here, around the iris itself. There's that flush, right? And why is there this light beam coming across the eyes? What is that? Slit lamp, that's right. So slit lamp is a super fancy, like, eye microscope, so much better than ophthalmoscope. And they'll sit with their chin in the headdress and you sort of scooch up next to them. You probably see something similar to it in ophthalmologist's office. And it does exist in many emergency rooms as well. Take some practice getting used to it. But then when you take a look inside the eye, you'll see what looks like snowflakes in front of headlights. That's what they call it. Or cell and flare would be the other buzzword you might see. And that's really just coming from all that inflammation and all of the white blood cells start floating around in that area. In fact, if they build up, they could form what's called a hypopion, which could cause an increase in pressure if there's enough of it there. And again, here you see the difference between iritis and conjunctivitis. Conjunctivitis is the conjunctiva, the sclera, the limbus is totally spared. Here with iritis, you have that paralimbic projection. And again, you may have this, in this case, you have an early sign, some irregular meiotic pupil, limbal flush. In this normal slit lamp exam, B, there's a normal reflection from the light. Here you have a cell and flare you can see in the pupil itself. You can see it almost looks like a light beam going through a dark, smoky room. For those of you who used to watch movies in the 1950s, smoky theaters, which I just did. Just imagine sort of like that projector light going through a smoky or funky room, right? That's what it looks like. Another picture of that is cells and flare. So if it's the first time and unilateral, you don't need to go chasing a systemic cause. But find out what happened. Was it conjunctivitis that never happened? Was there some blunt trauma that's occurred a little later? Is it traumatic iritis? I saw one kid who got shot in the eye with a nerve bullet, right? Day 1, 2, 3, was hurting a little bit. After day 3, all of a sudden, not a pain in the head. So you have day 3, a traumatic iritis. Could be autoimmune, but then you're going to see something a little more. It's not going to be the first time. If it's recurrent, if it's bilateral, then you might want to do a little more, or the HEP is a little suspicious. You might want to do a little bit more of a work of looking for some of those rheumatological or autoimmune diseases. Now, what's interesting about this is the redness in the eye. Like I said before, it's a different type of redness than conjunctiva. The redness with the conjunctivitis is all the superficial conjunctival vessels. With the iritis, it's from these deep arteries of the globe. So how can I tell the difference? Well, I can actually move the conjunctiva with a swab if it's just conjunctivitis. If I move it and the redness still stays in place, it's because it's something which is much deeper. If you're worried about there being some sort of intraocular pressure because of all that swelling and inflammation, don't dilate the eyes. Because what's going to happen when you try to dilate the eyes and you already have some intraocular pressure and it causes glaucoma, right? To explain to the patient, this is not just pink eye. You could go blind. You need to get good follow-up. Talk about ophthalmology, and they'll probably prescribe prednisolone drops every 6 hours, cycloplegics, over-the-counter NSAIDs. It does not need antibiotics. It's not an infection. It's inflammation. Unless there's a sign that it's infectious or something, but in general, it's not necessarily doing. And they need to be followed up within 24 hours. If you call your opto friend up on the phone and they say, hey, yeah, go and start doing steroids, we'll see you tomorrow, that's fine. That's fine, as long as there's really close on. Scleritis, again, it's this inflammation of the sclera. You can sort of take the words apart. Painful, destructive, potentially blinding. And it's again that constant boring pain, maybe coming to the face or periorbital area. Hearing photophobia, globe tenderness. See how this all seems differently by this. And because it's actually affecting the sclera, and the sclera injects have the extraocular muscles inserted into them, movement of the eyes itself will be painful. It's moving the sclera around. Going to look intensely red with the violaceous hue because those deep vessels are engorged. And again, they're not going to move when the conjunctiva are moved. You'll see again, because it's deeper, you might see some iritis with it, cells and flare, decreased visual acuity, corneal involvement, and it might be coming because of severe infectious keratitis, but most of the time it's going to be a secondary effect, sequela from rheumatoid arthritis or comorbidity of rheumatoid arthritis. You have to rule out glaucoma in such a case. Again, bright red eyes, super painful, even boring, and photophobic, so you need to rule out glaucoma. And get opto and rheumatology on board, because again, often it is rheumatoid arthritis, NSAIDs with postural use. And this is that violaceous hue we were talking. So you see how dilated everything is. And the sclera actually becomes somewhat thinner. Yes.
For scleritis,
Yes.
are we giving steroids, topical steroids, or do they need systemic?
That is a good question. I believe it's going to be systemic.
Like fraud?
Yeah, I believe so because of possible autoimmune. Yeah. I believe so. Now let's talk about glaucoma. So it's a painful, sudden vision impairment or loss. Might be some nausea, might be some vomiting, might be a headache. It will involve the limbus, a fixed, mid-dilated pupil hazy cornea. And it gets worse with dilation, significant photophobia. There's a rock hard eye. The intraocular pressure is more than 21, usually between 20 and 21, and you'll have the slit lamp demonstrating cell and flare. If it's painless, it might be chronic. I once had a guy come into, of course, because we closed at 10, he came at 9:50, and he said he had I think I just wanted to take a quick look at it. But the way he was describing it seemed funky. There's no discharge. It was like really painful, like a retroorbital pain. So let's get a visual cue. And it was garbage. You couldn't see out of that. And he ended up getting sent to the ED, and he had I think 60 or something. So red eye is just a red eye until it's not. Yes.
So basically, if it crosses over,
Whenever you see the limbus involved, always be suspicious for something. Okay. Limbus being limbal involvement, photophobia, visual acuity, loss of visual acuity, all those are super red flags of something deeper. Okay, and often the case will be where they just walked into a dark theater with their eyes dilated and that caused, right? It's not always related. It's usually related to that. People don't always get that. It's not from coming in a bright light. It's going to a dark theater. And this one, in this picture, you can see the normal iris in A, as opposed to B, where there's almost a shadow of the domed iris, because there's a more shallow anterior chamber. And that makes them more prone to acute angle blockage. So how do you treat it? Well, the goal is to reduce intraocular pressure, make sure there's not as much aqueous humor being produced, right? It makes sense. What causes glaucoma? Too much pressure and all this extra aqueous humor, blockage of the canal of Schwann. I don't remember. I have a reading vocabulary. And you give all the medications at once. You give a carbonic anhydrase inhibitor such as ceazolamide. IV or PO. You give a topical beta blocker,
Bless you.
such as timolol, and a topical alpha agonist such as apricot. Make sure there's no reason, there's no contraindication for the beta blocker, even though this time. Then come back in 1 hour, see how the intraocular pressure is doing. If it's not better, you might need to use some IV mannitol and hyperosmotic. Treat the pain and the vomiting. What is vomiting going to do to your intraocular pressure? Going to increase it, right? Zofran is not going to affect, so that's great. Fentanyl actually lowers intraocular pressure. Fantastic. 2 birds, 1 stone. Get Alpha on board immediately. Usually going to be admitted, they may even need surgery. How's everyone doing? Yes, I'm sorry.
Just real quick, you said you should not treat the vomiting with Zofran.
No, Zofran does not affect the intraocular pressure.
Okay, but you said fentanyl.
Fentanyl will actually lower it. Yeah.
Does it help with the vomiting? Okay, so all right, so you gotta give them both.
Yeah, fentanyl is one of those analgesics that are not going to have so much of a medical effect as some of the other opioids. And fentanyl actually lower it. Zofran on board will help with the vomiting is coming because of the pain.
Okay.
So that's two ways we can treat it. So again, if there's one thing that we have to continue to hammer home, if there's acute vision loss, there's acute vision loss, that's an emergency. Once there's acute vision loss going on, so it could be something painless, like central retinal artery occlusion or retinal detachment, could be something painful, like optic neuritis. There could be something that's not even painful in the eyes, like temporal arteritis, right? Temporal arteritis tends to be temporal artery, that's what that means. Could also be migraine, could be someone got hit in the head, they had some transient vision loss, could be psychogenic blindness conversion disorder. All that is usually going to be a diagnosis. If it's both eyes, what do I need to be worried about? Be worried about a possible stroke, more central, right? So we talked about the different types of retinal vascular occlusion. All this is just a table which sums them up. The main difference between them is that our arterial occlusion is a sudden, profound, painless loss of vision in one eye. You might find that cherry red spot in the macula versus the venous occlusion when you have sort of blood and thunder, one is more subtle, one is more dramatic. And arterial occlusion is going to require immediate ophthalmology because it's going to be irreversible after 4 hours, and they may even need TPA. With the venous occlusion, there's not much you can do acutely, but they do need to get the board of ophthalmology. So do you need a full neurological exam? Keep in mind, this is a central nervous system vascular emergency. You want to make sure that there's no other, this is basically a small stroke of the eye. You need to make sure that you're not missing anything else. Get Alpha on board immediately. Sometimes they might use eyeball massage or paracentesis of the globe for intraarterial TPA to help with the arterial occlusion. They can have a poor prognosis, while venous occlusion is more likely to recover the vision. You have that cherry red spot in the macula on the left and what? Temporal arteritis really is technically a vasculitis, systemically, but it can affect vision loss, so you have to have it on your differential. Headache, claudication of the jaw, fever, anorexia, often because it might be painful to eat. And tenderness along the temporal artery might be an elevated EFT and CRP, and it may involve optic nerve circulation. So if you suspect it, you need to get them on methylprednisolone immediately. If you're in a hospital setting, maybe if you're in a outpatient setting, you can start a PF, especially if there's vision loss. Retinal detachment versus vitreous hemorrhage versus posterior vitreous detachment. Again, these are almost always monocular. There may be those flashes and floaters that sometimes the only things we remember when we're doing our ROS during the standardized patient, flashes, floaters. But usually that's because you're worried about there being retinal detachment of some sort. And then it can be either over the optic nerve or the optic nerve can still be detached. Often this curtain closing over the eye. It's not necessarily an emergency, but it will explain the vision loss, and they do need to get in ophthalmology. Make sure you test visual fields to see where it is. Advanced detachment can be seen already with direct fundoscopy. Maybe an absent red reflex, maybe even a retinal flap that you see. And really need ultrasound and ophthalmology to do a full assessment. How you're going to manage it depends on if the macula is still attached, or if it's already detached. As long as it's already attached, you can probably do emergent surgery to halt the progression and preserve the vision. Both sides are going to need vision. So it's not necessarily something that needs to be done with appendicitis like this afternoon, but they need ophthalmology afterwards. Again, optic neuritis. This is where the optic nerve itself is affected. There might be some pain with eye movement, wide range of vision loss, again, only unilateral. Often it can be a visual loss of color vision, not necessarily acuity. There's a test we do called the red desaturation test. Bright red would appear pink. It is a gradual onset, relatively hours to days. There may be some visual field defects. An afferent pupillary defect, where we'll see a picture of what that looks like in the next one. And again, neuro, ophtho, MRI is going to be the best imaging for this. So, if you've seen this in this picture, what we see is it's called a swinging flashlight test. With an A, both of them look normal. If I shine the flashlight in B, in the right eye, patient's right eye, the left eye will constrict. But when I shine the flashlight in the patient's left eye, the right eye does not constrict. Neither does the left. The afferent pupillary defect. Why is that? Why is it that the right eye is not constricting when I shine in the left eye? Because it's a nerve issue, right? It's a cranial nerve issue. So the eye's just not getting the data. So why should the right eye constrict? It doesn't know what's going on, right? We may be able to get through eyes. We'll take a break. Okay. I'm sorry for everyone again late. If you have any questions, trouble catching up. All right, this is a foreign body in the eye. Okay, so that can happen. We saw some examples of that. Make sure that mechanism of injury was not high velocity, right? If it was high velocity, you need to do a CT. It might be a penetrating foreign body in the eye itself. Especially with metal, make sure you do a CT. Why not an MRI? Metal, right? Bad for everybody. You might want to get some topical anesthetic drops. Get a good visual acuity, fundoscopy, slit lamp if you have one, check the conjunctival stacks, do that upper lid flip. Sometimes you can use a Morgan lens and just irrigate the heck out of the eye. There's some sort of contact lens that you just put IV fluids through and just irrigates the eye. Maybe you'll be able to remove it with a moist swab. If you're pretty sure you don't see any foreign body, and there's no reason to think it's a penetrating, but they're still having a feeling of foreign body sensation in their eyes, consider there might be an abrasion involved. Do a fluorescein exam. If there is any corneal abrasion, I just forget to mention this, everyone must get a tetanus shot of a corneal abrasion. It's not just dirty lacerations, it's not just metal. any break in the skin, burns, corneal abrasions. And here is an example of how to use how to do the flip lid. The main thing again is to sort of depress the tarsal plate so you can see underneath it.
If you suspect that a foreign body is lodged under the upper lid, you must evert the lid. Ask the patient to look down. Grasp the upper eyelashes between your thumb and forefinger. Place a wettened applicator on the surface of the eyelid at the top of the tarsal plate. Flip the eyelid up over the applicator. Remove the applicator as you hold the everted eyelid in place with your other hand. Examine the pretarsal sulcus for a foreign body. If you find one, remove it with a gentle rolling motion of the applicator. Remove your hand from the eyelid and tell the patient to look up. The eyelid will flip back to its normal position.
One of the things that most people struggle with when they're doing the flip lid exam is A, being afraid of hurting the patient, B, being weirded out by grabbing someone's eyelashes, right? And C, not continuing to hold it up after you flip it. Okay. Let's say you do a fundoscopy and you notice shadows in the eye that could indicate a deeper foreign body. You need to check pupillary symmetry, the anterior chamber, make sure there's no iritis. If you see a Seidel sign, that could indicate there's a global rupture. Seidel sign, we'll see a few pictures of later. Could you actually see almost like an oozing of either the viscous fluid or of the fluorescein? In that case, if it is global rupture, and we actually do an eye shield. That's one place we absolutely always do an eye shield. We need immediate intervention. You want to keep the head of the bed elevated. Okay, so of the pressure. Sometimes a metal foreign body could leave a rust ring in the eye, even after you take the metal foreign body out. You can try to remove the rust ring with a corneal burr or a needle, or you can say, I'm not sticking the needle in anybody's eye. I'm going to send it off, which is what I usually do. But that's how you would treat it, and some people do. Irrigation, NSAIDs, topical antibiotics, make sure you hit the tetanus, and follow up in 1 to 2 days. If you see a large infiltrator or ulcer, assume it might be a bacterial keratitis of some sort. So here's a brace, so removing foreign body with a needle. And then here you can see that residual rust ring in the cornea following the removal of foreign body. Contact lens complications. This can happen after someone has left their contact lenses in too long. Might be an infection, might not be able to open their eyes because of pain, blepharospasm. Ask them, how long have you left your contact lenses in? Are you supposed to leave them in all day, every day, for 3 weeks? Or are they one-day uses we throw them? Fluorescein might find some dead epithelium, which might indicate an ulceration. There is something called Claire, which is a contact lens-induced red eye. There. With corneal infiltrates. Contact lens-associated red eye.
No way. Just